Hi everyone, it's Tammy Sherrill, and today we're going to cover the content around infants. And this sort of developmental stage is pretty much truly my specialty. I've worked a lot with infants in my career as a child health or pediatric nurse. Specifically started my career in the neonatal intensive care unit. Worked on general peds with mostly infants, and then I have a lot of experience with infants in the community as well, working as a public health nurse. So um, I love this class and this content. So just a little bit of review. If you think back to what you learned about pediatric assessment from loading week or block week, and specifically around infant assessment, there was some videos on growth and development, kind of providing a developmentally appropriate approach to assessment or examination, and how we might gain cooperation, also how we might use skills specifically around observation and whatnot before we actually touch the infant or disturb them. Page 176 of your textbook has a great little graphic around anatomic and physiologic characteristics or differences. And then lastly, the infant EXC module video covers a lot of great content around infants, but specifically attachment. And we're just going to review that in the next few slides. So attachment is a critical piece in infancy. And so, babies are born with that need to form close emotional bonds with their primary caregivers, caring, responsive adults. And this relationship is what child health experts and, infant attachment experts call attachment. It was first discovered in the 1960s by Bowlby, and still is an important focus today. And so when we think about characteristics of children who have that strong bond or attachment to their primary caregiver, just ponder that for a bit and think about, you've looked at resilience last week, and you looked at, what builds brains, the importance of relationships. And so I think there's a really close tie between attachment, that notion of Erikson's trust versus mistrust, and how that can contribute then to resilience moving forward. And so I've kind of alluded to this slide here. How are those three connected? And indeed, there is a lot of activities that parents or caregivers can partake in that help to form secure, happy, and healthy relationships with an infant and a child. And so some of the strategies, when we think of a hospitalized child specifically, would be hospital visits and how that has changed over time, how we used to have visiting hours or limit contact, and now parents really have 24/7 access to their children when in hospital. Certainly the notion of skin to skin and holding and touching are important aspects of building attachment. Building trust, so attending to and meeting infants' needs in a timely manner, whether they're hungry, whether they have a dirty diaper, whether they are tired and need to be consoled. Certainly we looked at family-centered care last week, so involving and having parents participate in care, providing information. Knowledge is power for parents. and that notion of a developmentally appropriate assessment as well. Okay, so let's leave attachment and move on to the first topic for around infant health alterations, and that is cardiovascular alterations. And in this section, we're going to focus mostly on congenital heart defects because that is the most common cardiovascular alteration that we see in children. And so when we look at congenital heart disease, it really constitutes a wide variety of malformations or defects that arise during fetal development. When we think about what time during fetal development that the heart is developed, it is between sort of week 3 and 9. So in the 21 to sort of 60-day range that the heart is developed. So very early on, often before women might even know that they're pregnant. And these malformations, the incidence is around 9 per 1,000 live births. Sort of over the last 15 years, it hasn't really changed. It's not increasing, but it's not decreasing. And when we look historically at congenital heart disease, the first surgery was actually performed in the late 1930s, and that was for a patent ductus arteriosus, which is a common malformation that can occur and common with prematurity. So, I think back even to when I started in child health in the 1980s, surgeries we're doing today, we didn't do back then. There was babies we just, basically they'd be born and we'd, wrap them up, keep them warm, put them in the parents' arms, and we didn't have a surgical procedure or a way to save them. And now we have those, and those kids are growing and developing and going on to become adults. So as it says there, 96% of infants with a congenital heart defect who survive that first year, because that's the critical year, that's often when you're going, having often frequent surgeries, those types of things, they will go on and become adults. So this little chart basically, there's a lot of acronyms here, VSD, ventricular septal defect, ASD, atrial septal defect. But what I really want you to get the sense of in this graph is that the most complex defects are the least common. So that's wonderful. The defects that are the easiest to repair, those top 3, the VSD, the ASD, and the PDA, are the most common. And when I look at the time frame along the bottom, we know that sort of echocardiography sort of developed in the 1970s. So you can see how there's quite a spike in sort of prevalence after 1970, because I think we were able to diagnose. A lot of times we didn't know what was going on before. And so some of the risk factors for a congenital heart defect would be exposure to any tetragens like alcohol, drugs, even smoking in utero, being a preemie specifically as well. Often congenital heart defects can be associated with syndromes. Common example is Down syndrome. Mothers who have viral infections get exposed to, say, rubella, that type of thing. Maternal age can play a role. So older maternal age, there seems to be an increase in congenital heart defects. And then genetics and family history. So we've only learned more about this in sort of the past couple of decades, because kids, now there's surgical repair. Those kids go on to become adults. They all have their own children. And so now we're able to look at a family tree and see that there is sort of a genetic predisposition. So let's look at congenital heart disease in Alberta. So, the 52,000 live births a year, and if we have a prevalence of 8 or 9 per thousand births, about half of those will need surgery. And so when we look at it, it's somewhere in the 400-ish range kids born with congenital heart defects, and then half of those will need surgery and chronic care. And here in Alberta, there's an open heart surgical program only in Edmonton. So any kids born in Calgary that require open heart surgery would go to Edmonton for surgery and then come back here for recovery and chronic care. And we are able to diagnose congenital heart defects prenatally now. If the mother presents with some signs and symptoms, or baby's not growing well, or that type of thing, they can do a prenatal fetal echo, and they can determine if the baby does indeed have a defect. And so let's begin to look at the main types of defects. And I know you've done some reading on this, and the textbook is actually quite excellent in regards to this. And then I also have some links on the straight PowerPoints, which I posted, that are to Toronto Sick Kids. Their website's called About Kids Health, and they have some excellent resources as well on congenital defects, with little pictures, animated pictures around blood flow and those things. So if you're needing sort of additional resources, that's an excellent one to look at. So some of the altered dynamics that we need to think about, these are kind of the foundational things that help us understand how these defects impact the infant. So just knowing that blood flows from an area of high pressure to low pressure. So for example, we know that pressure is higher on the left side of the heart than the right. So if we had an opening between, say, the left ventricle and the right ventricle, we know that blood would move from left to right, for example, high pressure to low pressure. Another concept is, as resistance increases, flow decreases. So if we had a narrowed valve, for example, say the pulmonary artery is narrowed, we know that there will be greater resistance, and as a result, poor blood flow out of that right ventricle to the pulmonary artery to the lungs. And then thirdly, resistance to flow increases workload on the heart. So say, for example, we had a narrowed pulmonary artery. We've got that right ventricle working really hard to pump blood through that narrowed valve. We know that that is just going to increase workload on that right ventricle. And just like you might go to the gym and work your bicep muscle, and the harder it works, the bigger it gets. Well, it's the same here, where we can end up with right ventricular hypertrophy. Okay, so let's look at the first sort of realm of defects, and it's defects that involve increased pulmonary blood flow. So as a result of this increase in pulmonary blood flow, what happens is we have pulmonary congestion and pulmonary capillary leakage, and that results in pulmonary edema. We also have then, as a result, less blood in the systemic circulation, and that can result in decreased perfusion to the body. And we have extra workload on the right ventricle, resulting in right ventricular hypertrophy. So some of the initial signs and symptoms we might see is most commonly tachycardia and tachypnea. those are initial signs, and those could be related to anything, but in this case, there's some of the early signs. And in addition to that, we might hear a murmur, and the an example of this is the VSD, which we're going to go on to look at. But specifically, we might hear a murmur, and as this child grows and develops, they may have poor growth, and they may have increased pulmonary infections because of this. So the example, the classic example, the most common congenital heart defect is ventricular septal defect. So as it says here, about 15 to 20% of all congenital heart defects. So interesting, the VSD can really vary in size and location. So it could be anywhere along that ventricular septal wall, and it might be small, might be medium, might be large. And there's also a VSD called Swiss cheese, where it literally there's multiple openings within that septum. So typically, because the lungs are non-functional in utero and have high pulmonary pressure, these babies are typically asymptomatic till pulmonary vascular resistance drops. So you can see from the little picture, we've got a hole between the ventricle. We know the pressure's greater on the left than the right. We're going to have blood flowing from the left to the right. You can see in the little picture how the red blood is leaking into the unoxygenated blue blood. We've got increased flow to the lungs. So that high pulmonary pressure is going to push back against that flow initially, and that tends to drop off over the first couple weeks. And so we may, depending on the size of the VSD, we may not see signs and symptoms initially. We might not even hear a murmur because there isn't great flow left to right because of that increased pulmonary pressure. So when that drops off, then we have that increased pulmonary blood flow. And the treatment really depends on the size of the hole, and it can range from anywhere from no treatment, the hole closes on its own if it's super small, to early surgery if there's a lot of blood flow across there. But the outlook for children with this condition is very, very good. And we would just go in, they would put a patch on that, and the child would probably go on to grow well and develop well and those types of things. Okay, let's look at the next major category, and this is sort of the flip side. It's the category that causes decreased pulmonary blood flow. And so here, the symptoms that appear depend on the severity of this narrowing or whatever is impacting the blood flow. So, once again, it could be small, medium, large. And some infants with decreased pulmonary blood flow literally fail to oxygenate. And so unlike the VSD, these kids can often present with cyanosis, and we can see this quite soon after birth. And supplemental oxygen really has little to no effect. So why would that be? We're giving the child 100% oxygen, and yet they're still not oxygenating. Well, it's because that blood is not getting to the lungs to be oxygenated. So all the oxygen in the world isn't going to make a big difference. So they can also go on to develop something called polycythemia, where it's just sort of a compensatory mechanism in the body where they produce more red blood cells to try and improve oxygen carrying capacity, but it's really not effective. And the polycythemia then can cause sluggish blood flow. It can affect clotting times. You could have cerebral infarcts. And ultimately, over time, they go on to develop clubbing, which is that convex nature to the tips of the fingers where the nail meets the fingers. There's a little picture here. There's probably a better one in your textbook that's more clear, but that can go on. And those are all signs of sort of chronic hypoxia. So one of the classic examples of this is pulmonary stenosis. So this is where the pulmonary valve is narrowed, it's malformed, or it's fused, and you can see where the little circle is in the picture. It's pinpointing the area of concern. So this is the fourth most common congenital heart defect. Compared to VSD, you can see less common. Uh, if that if that stenosis is severe enough, blood flow to the lungs can be minimal, and we then often have to do some early initial surgeries to try and improve blood flow to the lungs. Sometimes we'll take um, a subclavian artery and loop it back in to the pulmonary arteries to improve blood flow to the lungs, like post narrowing. And this defect can also really increase workload on the right side of the heart, resulting in right ventricular hypertrophy. So there's a little link here to pulmonary stenosis. That'll be on the slides I posted, and that's from Toronto Sick Kids, and it shows you a little example and a further description. Anything else I want to say about that? So these kids are really prone. This would be more of an acyanotic or a cyanotic defect, where they often present with cyanosis early and often need treatment much, much earlier than, say, a VSD. Okay, the third major category of defects is what we call obstructive defects. And these are where there is obstruction to blood flow from the left ventricle. So blood that has been to the lungs, been oxygenated, and now comes into the right ventricle, into the left, and should be circulated to the body. And so as a result of this obstruction, once again, when we have decrease or an obstruction to flow, puts extra work on the heart. So in this situation, we're having left ventricular hypertrophy occur. And sometimes ultimately blood eventually backs up into the lungs. So unlike adults where, you might have a right-sided or left-sided heart issue, a lot of times in kids, a left-sided issue can create a right-sided issue ultimately. So this is where we see, a left-sided issue causing back up into the lungs and creating, increased pulmonary blood flow. So signs of low cardiac output, you want to think what they might be. You probably know what some of these are in adults, but think specifically in infant. So once again, we'll have poor perfusion, diminished pulses as a result. You can have that prolonged cap refill. We can have then decreased blood flow to the kidneys, resulting in decreased urine output. We could have poor color. It could even just be pale, mottly looking to all the way to some circumoral cyanosis. We can have diminished flow to the gastrointestinal tract. So these kids can be at risk for gastrointestinal issues. They're certainly then at risk for pulmonary edema with the backflow into the lungs and ultimately congestive heart failure. So a classic example of an obstructive defect is coarctation of the aorta. You can see the percentage here, 5 to 8%. And what's really interesting, you see from the picture here, the most common point of the narrowing is where the PDA or patent ductus arteriosus. You can see that little small blue piece coming off the pulmonary artery there. That is the patent ductus arteriosus. That is what allows a blood to be circumvented from the lungs and go straight out into the aorta during in utero, part of fetal circulation. or prenatal circulation. And so that's the most common point. So something happens then when that PDA closes and pinches in and we have a narrowing there. So some of the interesting things about kids with a coarct is that the blood pressure is often is in the arms is greater than in the legs. So you can see that the brain and the upper limbs are being fed with good oxygenation off those upper vessels. And then we have the narrowed component. And so there's poor blood flow to the lower body. So sometimes we will do a 4-limb BP in these kids, both arms and both legs. And we'll often note lower blood pressure in the legs. Also, what might you note about the quality of the pulses in the lower extremities? They're often decreased or more faint as well. And coming from maternal newborn, I think a lot of you have. You probably learned about checking femoral pulses in a newborn assessment, because if the femoral pulses are weak, that could be a sign of a coarctation of the aorta. So most children will need a procedure. Sometimes they'll just do a balloon angioplasty. So they'll just go in and they'll put a little balloon in that narrowed area and blow it up and try and stretch it out. Ultimately, they may have to go in and surgically repair that with a stent or something. Studies show that long-term survival is shorter than average for people who have been treated with a coarct. And this isn't always something immediately diagnosed, at birth. I've seen as old as a 9-month-old come into the peds ICU. Historically had really poor growth and a lot of issues, but hadn't been diagnosed until 9 months. So here there's a little link to Toronto Sick Kids and a little bit further information and animated diagram of what's happening with this defect. I'm going to throw in one other example of the obstructive defect, and that's the aortic stenosis. So here you can see that the narrowing is much earlier than in a coarct, and there's a similar to issues with the pulmonary valve. These are issues with the aortic valve. So here, blood flow to the entire body would be impacted because the narrowing is much earlier. So have a little look at the link here. In order to practice, I wanted to share with you a defect which is fairly common. It's one of the more common complex defects, and it's called tetralogy of Fallot. So tetra being 4, these were 4 defects that come together that were discovered by this Dr. Fallot. So just thinking about pathophysiology while you explore this. So the 4 defects are, first of all, we have pulmonary stenosis. So that's number 1. And as a result of that pulmonary stenosis, we end up with right ventricular hypertrophy because that right ventricle is trying to pump blood out the narrowed pulmonary artery. We have a VSD as well. So now we have an opening between the ventricles. And if you remember from the VSD, typically we'd have blood going left to right, but because of that narrowed pulmonary artery, you can see from the picture is we don't have as much blood going left to right. And then the aorta tends to be positioned rather than over the left ventricle, kind of over the right and left together. So you can see it's more medial. And as a result of the picture, you can see that there's a fair bit of deoxygenated blood going to the body. So there's a little link here where you can go to the Sick Kids website and see a further description and an animated diagram of what's happening. But if we were to think about the pathophysiology behind this, then what signs and symptoms might we see in a child like this? So commonly we might see poor systemic perfusion. We might see some cyanosis with these kids, and they're actually prone to something called TET spells. And TET spells are where we have a sort of immediate and profound decrease in systemic venous return of deoxygenated blood. And so often this occurs with an infant during crying or agitation. It can occur upon wakening. And there's just this profound decrease in venous return, and they can become cyanotic very, very quickly. I've actually seen only one in my nursing career, and it was with an infant. It was in the morning upon waking kind of hungry and agitated, and that baby turned navy blue in seconds, literally. And so the treatment for this is typically to bring the knees into the chest, and or if it happens in a child that's mobile, toddler, preschooler with an unrepaired TET, they will often get into a squatting position, and that seems to be able to turn that around. So very interesting if you ever see one in your career, but it's really in an unrepaired tetralogy of flow. So how do we go in and fix it? It's not something you need to know for your exam, but we would fix that pulmonary stenosis, and we would close up the VSD. And so that can be often a stage surgery and obviously major open heart surgery. Okay, so leaving those four major categories of defects, I want to just talk a little bit about teaching children about their heart defect. So this applies more to preschool, school age. There's a little link here for something called the Heart House. It's a really valuable little website. And the Heart House makes an assimilation between thinking of the heart as a house with walls and doors and hallways and rooms. So a lot of times kids can understand or relate to this more simply. There's diagrams you can print off. Kids can color with red and blue crayons. That sort of thing. So when we think about a ventricular septal defect, it would be a problem with the walls. If we think about pulmonary stenosis or a narrowing of that pulmonary valve, it would be a problem with a door. And a coarctation would be a problem with a hallway. So it's just a fun little teaching tool. You can click on the link and have a look at it. So all children with congenital heart defects are at risk for congestive heart failure. And a high percentage of them, 15 to 20%, will go on to develop congestive heart failure at some point in time. We know from the adult world that congestive heart failure is really a failing of those compensatory mechanisms to be able to meet the metabolic demands of the body. And so there's sort of three major categories: impaired myocardial function, pulmonary congestion, and systemic venous congestion. So this is a little picture of an infant in congestive heart failure. You can see from the picture, this infant obviously is on nasogastric tube feed. Sometimes, infants need to be fed that way because their energy for eating and taking in adequate amounts is not sufficient. Looking kind of bluish in the lips, some circummoral cyanosis. Looking stressed, and you can see some sort of ascites or swelling in the abdomen area. So as I mentioned, in adults, you might see clearly right and left-sided failure. We don't tend to think of it that way in children as much, because often a left-sided failure ends up affecting the right and vice versa. So in infants specifically, when we look at impaired myocardial function, I've kind of highlighted the early signs in red, but the early signs typically are that increase in heart rate, and sweating or diaphoresis, and that can often occur with feeds. Feeding can be very challenging for these babies. Feeding requires a lot of energy. And then fatigue, lethargy, tires easily, as I mentioned, poor feeding. Other signs due to this poor myocardial function is decreased blood flow to the kidneys, so decreased urine output, pale, cool extremities, those weak peripheral pulses. We may see a decreased BP, and some cardiomegaly or enlargement of the heart just due to the extra demands on it. Under pulmonary congestion, the number one early sign we see is just tachypnea, an increase in the heart rate outside those normal limits. We might see some dyspnea or increase in the work of breathing, things like retractions, nasal flaring. We're going to talk a little bit about this under the respiratory assessment, and you probably ran across this in maternal newborn, but nasal flaring is just an effort by the infant to move more air and better oxygenate. Grunting, also very characteristic in infants, and grunting is an effort to keep those alveoli open at the end of expiration and prevent collapse. Because of the weak neck musculature and the large size of the head, we might see something we call head bobbing, where, with the increased respiratory effort, their head bobs up and down with breathing. Wheezing, crackles we might hear because of increased pulmonary edema, and they might have a cough. Under systemic venous congestion, none of these are really super early signs in kids. I'd say probably the earliest thing we might see might be some peripheral edema. But let's look at the first one. So weight gain, probably something you'll see if they are edematous. Hepatomegaly, so being able to assess the costal margin of the liver and see if it's down and if the liver is enlarged. The notion of peripheral edema. So because kids are not, infants specifically, are not up walking around, and we don't see it as commonly in the feet or the hands, we see peripheral edema periorbital around the eyes. We might see it sacral, where they might lie on their back, or in a male infant, scrotal edema. In an older child, we might see some ascites or complaint of abdominal pain in a child that is able to verbalize. We might just see an increasing abdominal girth in an infant. And then jugular vein distension. Obviously, you can assess that in adults, but way more difficult in children, especially an infant or a chubby toddler, or even a preschooler. So that would be more prevalent in school age or into adolescence. I had mentioned during the shock lecture that I would touch on cardiogenic shock. So this is really a sequelae of congestive heart failure. And it's really where there's inability of the heart to maintain cardiac output and tissue oxygenation and perfusion. And this is because congenital heart defects, some of them really impair myocardial function. And so the signs and symptoms of cardiogenic shock really resemble hypovolemic shock, but we don't see signs and symptoms of poor volume intake, blood loss, a burn, vomiting and diarrhea, like other things that would contribute to low volume. So I'm just going to touch on the top 6 goals around congestive heart failure, specifically with kids. And then we're going to be done. So to improve cardiac function is always our number one. And so here we reach for some of our medications that are going to help strengthen myocardial contractility. And our really number one drug of choice still to this day is digoxin. So there certainly are key nursing considerations and priorities when caring for an infant on digoxin. Some of the key things are monitoring serum levels for therapeutic dig levels. And so we often would draw blood on a regular basis when they're in hospital to monitor that. We need to take the apical pulse for 1 full minute before administration. And typically that would be part of the doctor's orders. They would say, because heart rate varies depending on the age and stage of the infant, don't give it if it's less than 90 or less than 100. Those are typically the kind of the standards with infants. The dose is always in micrograms, not milligrams. And this is sometimes a drug that we would for sure double check with maybe another RN before we give it, which is common practice at Children's Hospital, double checking of meds. And we want to watch for side effects and toxicity. So these medications, let me continue on to the other type of medication. So the other medications we will use to improve cardiac function are meds to decrease peripheral vascular resistance or decrease that afterload that the heart has to pump against to, get blood and oxygenate the body. And these medications will lower blood pressure and vasodilate the peripheral vasculature. So the heart has less resistance to pump against. So we have to watch for side effects and risks of toxicity with those as well. So very, very close monitoring. Something else I'd like you just to think about is commonly kids might go home on these medications. And so, as a parent, what are the things that we're going to have to teach them around, administering these meds at home, specifically with things like DIG. Parents are taught how to take a heart rate. Second major goal is removing fluid volume excess. So this can commonly occur and put extra workload on the heart. So medications commonly used are diuretics to remove this accumulated fluid and sodium. Lasix is an example. Spironolactone is another sort of example, more potassium sparing than depleting. So we monitor electrolyte levels really closely in these children. Sometimes they might need a potassium supplement if they're on a potassium depleting diuretic. Strict intake and output. Every drip and drop that goes in gets measured, and everything that comes out. So we are measuring urine output, weighing diapers, that kind of thing. Daily body weights. And then watching for skin breakdown in some of the edematous areas, which we've already talked about, where they can occur with infants, sacral and scrotal, that type of thing. Number 3 goal is to decrease cardiac demand. So we want to decrease any extra stress that we put on these children. So organizing our nursing care so as not to tire the infant and to make sure that they're getting enough periods of rest and sleep. We want to decrease infant stress as much as possible. So is that having that primary caregiver involved and their parent participation, parent proximity. With a little bit of an older infant, we might start to see separation anxiety, and that can create stress. So we want to do everything to decrease the amount of stress that could put extra workload on the heart. Really trying to maintain normothermia, because we know with a fever, hyperthermia or hypothermia, that can put extra stress on the body. And I think we've already talked enough about this. Careful intake and output balance. So fluid overload could cause increased cardiac demands. Number 4, improving tissue oxygenation and decreasing oxygen consumption. So we know with an increased metabolic rate, we can have increased O2 consumption. We also talked about the fact that more oxygen isn't necessarily better depending on the defect. And so we would give some supplemental humidified oxygen as ordered. Some defects, they might benefit from a half to a liter of oxygen, typically by nasal prongs. We want to increase the head of the bed because that's going to improve sort of diaphragmatic excursion, allow them to ventilate easier. Watching these kids with pulse oximetry, really careful and frequent respiratory assessments, auscultating that chest, looking and listening for sounds of crackles or any fluid on the chest. And then thinking about ways that we could decrease the work of feeding. So feeding can be, it can be like running a marathon for some of these little babies. And so sometimes we might give extra blow-by oxygen during a feed. And we're going to go on to talk a little bit about feeding in the next slide. But that's probably one thing that can really increase O2 consumption. So we need to think about that. So let's talk about maintaining the nutritional status. So and decreasing oxygen consumption. So smaller, more frequent feedings can help. So we're not trying to get this entire bottle down a child and taking 45 minutes or an hour to do it. We'll give smaller, more frequent feeds. Limiting the bottle feeding time to a half an hour max and being able to give them breaks. So allowing them to feed, take the bottle out, let them pant, recover, and then, cue us when they're ready to feed again. They might require, as I mentioned previously, nasogastric tube or G-tube feedings, depending on how they're growing. A lot of babies have to reach a certain weight before surgery, typically 5 kilos. So sometimes we're trying to, fatten these babies up, but we don't want to be overfeeding them and fluid overloading them. So we need to sometimes provide higher caloric feedings to be able to meet the metabolic needs, have them gain weight without the extra fluid. So, breast milk, for example, is usually 20 cals per ounce. We might go, add some additives to breast milk or to a formula to increase caloric up to 24 or 27 cal per ounce. And gastroesophageal reflux is common in kids with congenital heart defects, whether it's, venous congestion, pooling of blood in the liver, increased, pressure on the stomach. Some of the more of these babies are prem and they might have, poor lower esophageal sphincter contraction. So for a variety of reasons, reflux is more common. So they take in their feed, they puke it all up, and we're starting at square one again, trying to have them grow and develop normally. And the last one is support for the family. When these babies are born, often cardiac defects can be a invisible condition, right? You might not see signs and symptoms. These kids might look completely normal. They might be a big, chubby, healthy looking baby, but so it's this invisible defect, and lots of teaching and education around understanding the defects, the medications, the surgery, care of the child, ultimate discharge home. And there's a whole outpatient clinic at Alberta Children's Hospital specifically for families of kids with congenital defects. And they have parent support groups and that type of thing. So support for the family, really, really important, especially in those initial stages. Okay, that's everything. I hope you enjoyed it. Thanks for listening.